Hello, this is Jessica Hoy, and today I'm starting a series of recordings about heart failure and other structural, easy for me to say, problems. So let me share my screen and I will get right down to it. So this particular recording and series of recordings is actually a combination of both chapters 34 and 36. So in Lewis, so both chapters 34 and 36 in Lewis are about structural problems and like problems with how the heart fails. So that's why they're combined, just so that you know. It'll be a series of different chapters. And so now I'm going to start the heart failure chapter. There is some things that you should know about heart failure. This is basically a pathophys review. So heart failure is a complex clinical syndrome. And basically there's insufficient blood flow supply, oxygen to the tissues and organs. And that creates a decreased cardiac decreased cardiac output leads to decreased tissue perfusion. So it's kind of like this a never-ending cycle with cardiac heart failure because the heart can't move the blood, right? But then that also leads to decreased tissue perfusion of the cardiac muscle. So then the heart really can't move the blood. And the way we measure the effectiveness of the blood is through this thing called ejection fraction. And it's a percentage. If your heart's doing, if that left ventricle and the right ventricle, if the heart is doing what it needs to do with those ventricles, the ejection fraction in that left ventricle is 100%. So less than 60%, we start getting pretty concerned. Less than 20%, there you're going to need some mechanical interventions that we'll keep talking about throughout the slideshow. So you can have heart failure without or with a reduced ejection fraction. So that heart failure can cause an ejection fraction reduction. And so then that creates a problem with the ventricular systolic function and then that left ventricle contraction. Or if you have a preserved ejection fraction, it means that there is a problem with filling. So either you have a problem with getting things out, which is the ejection fraction, but if you have a preserved ejection fraction, it means you have a fill problem. So there's not enough blood that gets into that ventricle before it gets pushed out and becomes cardiac output. So heart failure is the result and is associated with many different cardiovascular diseases. It's increasing in incidence, it's increasing in prevalence, partly for some good things. So people are living longer, and we have really good interventions for cardiac events. So then more people in the world are living with heart failure. And it is the most common cause for a person's hospital admission over the age of 65. Medicare does have some pretty tight parameters about what they will and will not cover with hospital admissions. That's something for another time and another place and another discussion when we're talking about healthcare economics. But there are economic repercussions that can be easily associated with heart failure as well. So the primary risk factors, just like I said in week 8, after that test, hypertension. So that is a modifiable risk factor. If we can keep a person within a healthy zone of blood pressure through different interventions, such as diet, exercise, medications, combination of all three, we can modify that hypertension and hopefully not have it create heart failure. If we are aggressively treating and managing that hypertension, we can reduce the incidence of heart failure by 50%. So woohoo, we can cut that number in half just by getting the hypertension under control. Coronary artery disease, which is something we talk about in week 9, is also something that can be a primary risk factor. It's also it's a modifiable risk factor as well with diet, exercise, medications, different sort of like combination therapies, getting that coronary artery disease under control. And a lot of comorbidities can contribute to the development of heart failure as well. So COPD causes heart failure a great amount of times. So does obesity. But the etiology of heart failure is it's an interference of mechanisms regulating cardiac output. So there are primary causes, conditions that directly damage the heart, like hypertension. And then there are precipitating causes. Those are conditions that increase the workload of the heart. So I know in the last slide I mentioned obesity and COPD. In COPD people with COPD, they can actually have that because those tissues are just unhealthy, right? And they're not doing the gas exchange the way they should, that there's a lot of capillary resistance in those alveoli because they're sick, right, from the emphysema. And so, which is half of chronic or COPD. So the emphysema, in addition to remodeling the alveoli and having them be all little clusteries, makes them into kind of big balloons, that changes the capillary beds. The capillary beds changing increases the workload of the right ventricle because the right ventricle has to work that much harder to try and get the blood into the lungs through the alveoli and then back out and doing that gas exchange. So that's one of the an example of a precipitating cause causing a heart failure. So left-sided heart failure, it's the most common cause. It results from the inability of the left ventricle to either empty adequately during systole or fill adequately during diastole. There's systolic heart failure, there's diastolic heart failure, or you can be a combination of the two in terms of classifications. Basically, the blood backs up into the left atrium. It causes increased pulmonary hydrostatic pressure, and that increased pressure causes fluid leak from the pulmonary capillary bed into the interstitium and then into the alveoli. And that results in pulmonary edema, pulmonary congestion. It's not that they have an infection in there, but you can listen to a person with heart failure and if they're having a really hard time, they have shortness of breath. And the reason why they have shortness of breath is because they have swelling in the lungs. There's also right-sided heart failure. That was left-sided. Now we'll talk about right-sided. And that means that the right ventricle doesn't pump effectively. Fluid backs up into the venous system. Fluid moves into the tissues and organs, creates that dependent edema, wreaks havoc on the liver and on the GI system. And the most common cause of right-sided heart failure is left-sided heart failure. Other causes can include right ventricle infarction, pulmonary emboli, and cor pulmonale, which is a right ventricle dilation and hypertrophy. So it's bigger and it's more muscular and is just not able to really squish all that blood through the lungs as what it needs in the pulmonary system. And then we can have biventricular failure where they both fail. And then that's the inability of both ventricles to pump effectively, fluid buildup, and there's venous engorgement, and there's decreased perfusion to those vital organs. So here is a picture of dilated heart chambers, dilated ones. Look at how big those enlarged ones are. And then here's that hypertrophy with that thickened heart muscle. So in this one, in A, the blood can get in, but it can't get out because there's just too much space and there's not enough heart muscle. In B, there's just not enough space and we have too much because we have too much heart muscle. So just that's kind of the visual version of both dilated and hypertrophy. I'm going to stop here. I'm going to pick up with some clinical manifestations of pulmonary edema in the next one. Stop sharing. And I will see you in a few minutes or whenever it is that you get to number 2, heart failure number 2.